Thank you, hardy souls, for showing up and braving the nasty weather, which seems to have dogged our entire housing series, but welcome. I'm Rosalie Ginevra, the League's Executive Director, and especially happy to welcome you to this culminating program in our series, which will give us a chance for some lateral learning from efforts to improve one of the other complex, huge systems that is so important in our society, namely healthcare. If you missed any of the earlier programs in the series on topics ranging from technological innovation to zoning reform to the potential and pitfalls of small dwellings, you will be able to see the programs on archleague.org, the League's website, in several weeks. Before going any further, I want to acknowledge and thank Emily Schmidt, the League's Manager of Housing Initiatives, for her central role in conceptualizing and organizing this series, and all of the other housing programs and publications that the League's produced over the last several years. I also want to thank Andy Bernheimer, who's here, and Moses Gates, Rosanne Haggerty, Paul Lewis, Nadine Male, and Qasim Shepard for their help and advice in formulating the housing system programs, as well as the entire Architectural League staff for all the different kinds of work that it takes to make our programs happen. And I'd like to invite you to join us for a reception after the program, if you have the time, at the League's office, about a block and a half away, where we'll have some refreshments and a chance to continue the conversation. The impetus for the League to organize this series was, in part, a desire to critically examine some specific issues of housing policy and design, such as the intense current fascination with small and shared dwellings as potential answers to some part of our housing problems. We also wanted to call attention to often overlooked topics, such as the importance of maintenance and ongoing operation. And we wanted to create an opportunity to hear from innovators in regulatory reform, advocacy, and technology. More broadly, though, we were spurred by a strong sense, shared by many, we believe, that the immensely complicated, very expensive status quo of how we finance, build, and occupy housing is not only neither efficient nor just, it is not productive for us as a society that has so many needs that we need to focus on in order to move forward, from education to criminal justice to the climate emergency. It's both immoral and irrational to have so many fellow New Yorkers and so many people in cities across the country homeless or burdened with unsupportable housing costs that limit their other opportunities in life. An affordable, stable place to live is essential to a manageable life. We were also propelled by the belief that though housing is comprised of many, many different parts, from design and construction conventions to the influence of banks, to regulatory regimes, to property tax structures, to cultural preferences, to demographic change, and though it may seem to operate in separate arenas of affordable and market and homelessness and luxury, it is in fact a dynamic, intricately interconnected system. To make substantial change, we need to be able to see what we have as a system and start to understand how far-reaching, profound changes in complicated systems are catalyzed and enacted. Which brings us to this afternoon. We're extremely lucky and honored to be joined by two extraordinary people, both of whom have had enormous influence in their fields because they're willing to ask big questions, are able to articulate their own values and the goals they want to achieve, and because they have the creativity and boldness to lay out challenging courses of action to achieve those goals. They're both so accomplished that I'd like to add a little bit to the biographical information that you have in your programs. Donald Berwick has been a leader in efforts to raise the quality of healthcare for more than 40 years. He trained simultaneously as a pediatrician and in the public policy school at Harvard, receiving his MD and Masters of Public Policy degrees the same year. Throughout his career, he's both practiced as a clinician and worked in the policy arena. In 1983, he became Vice President of Quality of Care Management for the Harvard Community Health Plan. And in 1991, he founded the Institute for Healthcare Improvement, which is a nonprofit educational and advocacy organization which has grown to have a worldwide presence as an influential change agent in healthcare systems. IHI bases its work on the science of improvement, which it describes as an applied science that emphasizes innovation, rapid cycle testing in the field, and spread in order to generate learning about what changes in which contexts produce improvements. In 2010 and 2011, Don led the Centers for Medicare and Medicaid Services in the Obama administration, helping develop the organizational structures through which the Affordable Care Act was put into effect. In 2013, he ran for governor of Massachusetts with a platform focused on creating a single-payer healthcare system, ending child poverty, and job creation. He's the recipient of many, many awards, including the 2002 American Hospital Association's Award of Honor, the 2007 Heinz Award for Public Policy from the Heinz Family Foundation, the 2012 Gustav Lienhardt Award from the Institute of Medicine, and the 2013 Nathan Davis Award from the American Medical Association. In 2005, he was appointed Honorary Knight Commander of the British Empire by Queen Elizabeth II, the highest honor awarded by the United Kingdom to non-British subjects in recognition of his work with the British National Health Service. Rosanne Haggerty is the President and Chief Executive Officer of Community Solutions, an organization that she founded in 2011 that operates across the United States and consults internationally to develop and employ strategies to end homelessness. Their large-scale change initiatives include the 100,000 Homes and Built for Zero campaigns to end chronic and veteran homelessness, and to work with neighborhood partnerships that bring together local residents and institutions to change the conditions that produce homelessness. At South by Southwest in Austin earlier this year, Rosanne and Kaiser Permanente announced that Kaiser Permanente will provide $3 million over a 3-year period to the Built for Zero initiative, which uses real-time data to help local leaders better understand the dynamics of homelessness in their communities. Since 2015, working with community partners in cities across the country, the Built for Zero initiative has provided housing to more than 65,000 veterans and 38,500 chronically homeless Americans. 3 Built for Zero communities have ended chronic homelessness, and another 9 have ended veteran homelessness. Earlier in her career, Rosanne founded Common Ground Community, where she developed path-breaking approaches to the creation of supportive housing by paying close attention to the real needs of clients, by leveraging previously untapped resource streams, and by recognizing the potential of previously ignored buildings as resources for her work. Rosanne, too, has received many, many honors, including 6 weeks ago, the 2019 Award of Merit from the New York chapter of the American Institute of Architects. She's a graduate of the Columbia University Graduate School of Architecture, Planning, and Preservation. We're going to start with a brief presentation by Rosanne, who will then be joined on the stage by Don for a conversation. So please join me in welcoming Rosanne Haggerty.
Thank you, Rosalie, and Emily as well, not just for today, but for organizing this whole series and posing this question, which I think is really so central to all of us here in New York and frankly in any city looking to have a just environment. So when I first met Don Berwick, I think it was in 2003, I was introduced to this quote, which really deserves to hang in the background here throughout our conversation today. It's been attributed, I think, to Edward Deming, one of the founders of IHI, in addition to Deming, and also Bucky Fuller seemed to have said something a bit like this. But a system, and I remember when Don, at that first meeting, talked about systems, I was there thinking to myself, no, what's a system? Well, the idea that there are, whether we acknowledge it or not, these interrelated relationships that guide how reality unfolds, frankly. And in the case of healthcare, which you'll hear from Don, he has taken on throughout his career to, first of all, inform actors in the healthcare system that they need to operate as a system. We see that that mindset is critical to having an approach to housing and approach to homelessness as a symptom of housing system failure, that it actually gets us to a place where we wish to be as a society. Because if it's true that every system is perfectly designed to achieve exactly the results it gets, what can we actually say as New Yorkers to defend this? We are spending more as a city than any other city in the country. We have more individuals and families experiencing homelessness than any other city in the country. We are spending more on housing than, as a municipality, than any other city in the country. And yet we have 462,000 households that are paying more than 50% of their income in rent. And as Rosalie just mentioned, and research is showing in many places, what that means is our neighbors are going without food, children are going without needed resources to support their growth and development. The consequences of having a housing system that we tend not to think of as a system, but exists there nevertheless, that is this poorly designed and getting results that are this poor, really is a matter of urgent attention and needs to be a matter of committed design attention for all of us. Now, let's take a look for a moment to just set the context for this conversation about, what are the components of our housing system? Well, these are just sort of a beginning list, from zoning and land use policy to financing to our rent regulations, onto the types of housing that we have invested in as from the public sector, public housing, transitional housing programs, shelter. We have, as the series has examined, different housing typologies, different approaches to maintenance, different occupancy rules. And one of the characteristics of a system is that even if it's not conscious of itself as connected, that small changes in any one of these activities and policies can really wreak havoc on other outcomes that the system desires. And so one of the things that I hope will be actually coming back to as the result of our conversation today and through the conversation with Dawn is, what if we were to get intentional about a clear, measurable aim for our housing system and start thinking about and designing our activities with the intention of actually arriving at a goal we desire as a city? And I would say that the right aim for our housing system is minimally, and I think it's important to keep it simple. All of these activities add up to zero homelessness, meaning homelessness is mainly prevented. When it happens, it's quickly resolved. And that we have no families paying anything like 50% of their income on rent. That we actually measure these things, that we understand first and foremost what the ground truth is, and try to see the system whole by understanding how of these parts, these levers we have to create a different reality around our housing could be employed against those very clear measures. No homelessness, and no one is paying more than 50% of their income in rent, and that number is coming down. Now, that might sound crazy in a city that now has more than 60,000 individuals and members of families experiencing homelessness, and 462,000 families that are rent burdened. But one of the things that I want to hypothesize today, and we'll hear from Don about his experience, is that in a well-functioning, well-designed, and accountable system, you're putting your resources against your aims. You're not starting with the assumption that you don't have enough. You're starting with the commitment to have the right people around the table who control the critical levers, and with an understanding of what the system actually looks like. I mean, who are these 462,000 families? Who are these 60,000 individuals? And what do we need to know about them and the conditions that have actually brought us to a place where they're in such an untenable situation housing-wise that we need using all of these levers to correct. And one of the other things I'll observe, in the addition of questioning whether this is a money problem and wondering if having a clear aim isn't the starting point, is to ask a question about how nimble these tools actually are. When's the last time we tried to change zoning? Well, anyone in New York knows that a ULURP process or any even spot rezoning, you're looking at about 2 years. Or to change a policy, or to change the way a program is designed. The lead time for any significant change can be measured in years when people's avoidable suffering is happening in real time. And so one of the things that a healthy system and an agenda for us, I believe, in moving in this direction is to have a time scale that matches our ongoing learning and understanding of the nature of the problems we're experiencing in our housing system. One of the things in addition, and we'll be listening to Don's description of how in a big, hairy, complicated, seemingly uncontrollable healthcare environment, he and others have shaped a real consciousness of a system with accountability for improved healthcare for many Americans, and Don will tell us where that journey is. But the lessons that we can take from Don's work in healthcare are also informed and should inspire us in thinking about our housing system, are also informed by progress being made on equally tough problems that require lots of people who do not control each other's activities to collaborate and coordinate their activities in real time, to share whatever information is needed to improve what they're doing against a goal of keeping especially the most vulnerable safe. We have learned so much from IHI since 2003. They've mentored us in our application of improvement science to ending homelessness in now 74 communities where we work. And as Rosalie said, many of them are making just transformational progress. But we've also learned from other industries that IHI has pointed us toward, for instance, aviation and other high reliability industries, complex construction, for example, or nuclear safety and nuclear power plant safety, that all around us, people are figuring out how to coordinate, solve complex problems that involve multiple actors working together against a clear common aim. And as we start our conversation with Don today, I just want you to keep in mind that this is not some fantastical notion that we can actually, as New Yorkers and as residents of any city, expect our systems to understand themselves as systems, to be accountable for results, and to get to worthy aims where the most vulnerable among us are not living on the streets, on subways, in shelters at billion-dollar costs, or struggling to stay housed and doing without essential things that will keep those families safe and healthy. And so I'd like to welcome Don to the stage and really go immediately into the notion of how we can learn from his experience and from how other sectors have begun to form around bold and accountable ideas, and how we can begin to apply this way of thinking to our housing needs. Don? So Don, you were one of the first people anywhere, I think, in the healthcare system in this country to begin to see that quality was slipping and that it really wasn't so much a money issue, but in fact, there's a widening gap between the amount of money being spent on healthcare and the outcomes. And you identified that early on as a coordination and an accountability problem. You didn't go to the usual place with just send more money. You know, that you recognized something else was afoot, and that you identified that as a systems problem. I'd love you to describe for us your early insights, how you came to that aha, and how you began the work of building a systems approach and sharing it with others.
Thanks a lot, Roseanne. Let me also begin by thanking Rosalie and Emily and all of you that's made it so easy to be here. I'm delighted to get to know the League and to join in this conversation with you. And as on a caveat emptor basis, as I said on the phone today, I don't really know housing, so I can talk about healthcare, but I'm not being glib about carrying.
We'll try to do the
that's
translation.
Your job, right? But the answer is I got it wrong before I got it right. I mean, so I'm a pediatrician, but I also got trained in public policy and clinical and evaluation. And we actually had quite a bit of evidence in this country as early as 1990, 1985, on defects in the healthcare system. It wasn't widely known by the people giving care. Certainly we weren't trained in it, but there was evidence of injury to patients from errors in medicine, which are rampant. We kill more people in hospitals with errors than die of breast cancer. We have strong evidence of variation in practice. So when you see a doctor, you're kind of rolling dice. What happens to you isn't standard. It's not according to science. It's according to local practice. And we have courageous researchers who unmasked this variation back in the 1980s. We have evidence of leaving people out, racial and socioeconomic gaps in health status. I mean, I could go on. Problems of timeliness and enormous waste. We're twice as expensive as the next most expensive country in healthcare, and our results are terrible. We're 56th in infant mortality, 43rd in life expectancy, so it's a low-value system. All of this was known really in the 80s and 90s. By scientists. I was one of those scientists. That was my research area. But I was also put in charge of quality in a health maintenance organization. Long story there, I won't go into it, but I was supposed to make things better. But what I didn't work. I realize now I was working with bankrupt approaches to taking action for improvement. Approaches like measure and show the data. And then a miracle will happen. I later heard a proverb somewhere in Africa where I was working that weighing a pig does not make a pig fatter. And I kept weighing pigs, hoping the pig would get fatter. Exhortation, just kind of, hey everybody, let's fix this, as if they weren't already trying to. Or worst of all, I think, blame, sort of finger wagging. Or like I was trained as a doctor, a call to heroism. Just try harder, doctor. Don't screw up. And that was my approach. I got paid a lot of money as a vice president of an HMO to do all this reporting and stuff. It wasn't working, and so I got very frustrated. And really, it was 1986, 87 when I through a whole series of accidents, I met some of the people who you've quoted on the slides there: W. Edwards Deming, Joe Duran, people who had worked in other industries. Aviation, manufacturing, who actually were doing steady improvement. Aviation is many orders of magnitude safer now than it was even 10 or 20 years ago. And I studied how it worked, how they did it, and that's when I discovered the stuff you were talking about, that you have to think differently. This is not about exhortation, it's not about heroism, it's not about measurement, it's about thinking and acting all together as a system, as dry as that word is. And so that's what started me going. That's what started the Institute for Healthcare Improvement, and that's been the message and the work that I've been with colleagues carrying on for decades now. But I had to be wrong before I was right.
I remember, I think, in some of those early meetings that you hosted with my colleagues and me, you shared with us not just your thinking about actually forming a system and what the ingredient parts were, but also of spreading a new way of thinking and working and the diffusion of innovation strategy. Maybe, I remember how game-changing that was for us to hear that, and I think it goes with your insight around it's not just exhortation, you have to kind of change the way people think, and you also have to create a new club to belong to. Maybe you could say a bit about how your strategy...
Well, it's hard. I mean, think of it as there's aims, and then there's methods, and then I guess there's context. That might be how I think about it. The aims you talked about, which is in healthcare, by 2000, we had our aims. The National Academy of Medicine had produced a report that I helped write on called Crossing the Quality Chasm, and it laid out 6 aims for improvement. They were safety, stop injuring people, effectiveness, use science and care, don't vary so much unscientifically, patient-centeredness, give control to the people we're trying to help. Timeliness, stop delays, uninstrumental delays. Efficiency, just don't waste all that stuff. And equity, close racial and socioeconomic gaps. So that's a canonical list in my field. Boring words, I guess, but safe, effective, patient-centered, timely, efficient, equitable. You never improve without aims. It can't be done. So that's the first step. Then there's method, and that's what we talked about. The old method is yell louder, measure more. Accountability, by the way, is not a word I'm friends with. I don't think it's a good idea. It's too much a cousin of exhortation. Knowledge is important, but we have to be careful about accountability. So what is the method? The method is pretty simple. Just watch any child. They're approaching getting better all the time. All healthy kids do. And they do it through a kind of, you could debrief it as a systematic approach. I noticed you had the model for improvement up here in one of your slides. You want to pop it up there? This was the method that I got introduced to. This is kind of the micro method. So when you try to make something better, whether it's your souffle or your marriage or your golf game or your healthcare, there's 4 things that are going on. Any child is doing this, learning to play baseball. Set a name. I'm going to learn to throw straighter. Come up with some way to know if you got better. If you don't know if you're getting better, if you don't know when you're getting better, you can't figure out what works and what doesn't. So you have to have some way to sense effect, which doesn't have to be quantitative, but it just has to be available. That's the second part. The third part is don't keep doing what you're doing. Find something else to do. If you swing the bat the same way, the ball's going to be hit the same number of times. Every system is perfectly designed to achieve the results it gets. So switch your grip. So you have to have a way to find the other thing that you aren't doing. That's finding a change. And then the fourth part of the model is this icon, the plan, do, study, act. That's a mnemonic that just means try it out and see if it works locally. It's not in a laboratory, it's in real life. This comes from Tom Nolan, our unfortunately recently deceased colleague. I know you were close to Tom too, and his colleagues and associates in process improvement. Set a name, figure out how you'd know if it got better, find something new to do, and put it to work. That's the method. So those are the first 2 keys. And this is much better than exhortation. It's learning. In my world, the word improvement is almost synonymous with the word learning, which is also almost synonymous with the word change. I wish there must be a language in which improving, changing, and learning are this, like there's a common word, maybe there's a word in Japanese or something. So that you have an environment for learning. Now, the problem is the system. It's an interdependent system. When you're learning to bake a better souffle or do better at tennis or golf, you can pretty well do it yourself. There are interdependencies, but it's pretty well your game. In anything as complicated as healthcare or I assume housing, it isn't golf. It's at least doubles tennis. Mm-hmm. It's us, not me. Mm-hmm. And so how can you have an aim and then use a method in common in an interdependent environment? And that's the context. And it's unfortunately leadership dependent. Leaders do all sorts of stuff, which we can talk about, that make it more likely that you can learn as opposed to just feel bad or good. And it's also depends on structures, structures that allow for interdependent work to occur. In the work of IHI, we early on discovered that people do want to do this, and it's possible to set up social structures, permanent or evanescent, which allow people to come together to work together. They're smarter together than they are separately. They get more done together than they would separately, and you can set up those structures. We call those, the original phrase was breakthrough series collaboratives. That's what we came up with in 1995. We would call, like our first one was on cesarean section rates, which are insanely high and remain so. But everybody knew it, and the American College of Obstetrics and Gynecology were estimating we did about twice as many as we should. So we just put out a call. We said, hey, any hospitals out there you want to work on cesarean section rate? 33 hospitals said yes. We formed a collaborative, and over 18 months they worked together using this model on cesarean section rates. And that general finding of creating a context for people to work together who otherwise wouldn't meet each other in healthcare has been not quite magic, but pretty close to it.
Well, Don, maybe you could say a bit more, because this is so crucial, about what you've learned about what it takes to have a group of disparate actors begin to see themselves as an interdependent system, to make that system visible. And are there general lessons, I can share.
Careful, 'cause
I can share a few from housing that we've seen, but
Well, we should hear you
yeah.
say in housing where you've seen that.
Well, yeah, I'm gonna. This is actually. This is kind of back to sort of a health example, but we found that you need to create a common table in ending homelessness in any community. It needs to be the mayor or county executive's office, the continuum of care, which is the cluster of not-for-profits who receive HUD resources, the VA, because they have resources for homeless veterans, and housing authority staff. That group needs to see themselves as joined at the hip, as solving the same problem, sharing the same aim, and meeting regularly to improve, to look together at the data, to kind of hypothesize what needs to be done next based on the data. And we often, when we're starting the sort of initiation of a new community is Join Built for Zero, we'll show them this picture, which of all things is, this is the group in, I think, Nigeria working on the last mile push to end polio. You can kind of, it's the same idea, from community health workers to people from the WHO. Everyone top to bottom needs to be at the same table, looking at the same data, and then going out and doing the job that they agree needs to be tested and learned in response to the data. So it's the same methodology, and this is actually what's getting the job done on ending homelessness in the communities that are participating and working this way. But what are your insights?
Well, that's. I wish I'd said it your way. This is right. I mean, the question on one's mind when you see this, it's sort of obvious. They can't do it separately, but they might do it together. You can't stop polio alone. You got to do it as a system. There's an interaction. Why are they in that room? Who pulled them together? What triggered the connection? In a corporation, it's executive leadership and the board. They're setting a culture in place, and the signal could be sending out to the workforce, you're competing with each other, the best player wins, the others lose. That's a signal, but that's not going to make this table happen. There's a different kind of signal which says we're all in this together, we're one place, we have a strong mission, we depend on each other, and I depend on you. And so leadership to create this table really matters. There's a belief system involved here. I have 7 grandkids, and the second oldest is Caleb, who's 7 years old, and I was taking care of him this last weekend, and he's an avid soccer player. He's pretty good, and I said to him, actually my wife said to him, he just had a game, said, "How was your game? How'd the game go?" And Caleb, who scores goals all the time, said to my wife, "I got an assist," and he was just as happy reporting an assist as he would be reporting a goal. We need that. That's a belief system. I got an assist, and if housing would get better if everyone celebrated that they got an assist, not just a goal. That's leadership dependent. A couple of lessons. One is, I think in healthcare, in healthcare, I don't know about housing, the workforce wants to do this. People don't want to be islands. It's much more fun to be on a team. Everybody knows that. And when you create an environment in which people can share their efforts and learn from each other safely and celebrate together, you've uncorked change. You're not forcing it, you're releasing the change, which is latent. It is leadership dependent, unfortunately, always, that somebody's got to say it's we, not me, and and we trust each other. And by the way, on that model for improvement, think of each step and the threat. Setting an aim, what if we fail? Are you going to celebrate ambition, or are you going to? What about zero homelessness? Some leaders would say, no, we can't deliver, we'll fail. That's not going to work. Measurement? Well, measurement today, because we're in an environment of exhortation and punishment and blame, is a threat. The workforce has learned to game the measurement. They're just trying to make it look good because that's the way to be safe. How can a leader set an environment in which the psychology of measurement is the psychology of curiosity? And aren't I glad I know that now? And then there's finding a change. If everybody's belief is, if we haven't invented it here, it hasn't been done. What could we possibly learn from New Jersey? You're not going to work. Believe me, most of the smart people in the world are not in this room, no offense. So go find all of the other stuff you don't know about and bring it in, which means the leader has to invest in that and set a tone of search. And then the last, PDSA, no kid learns to ride a bike without falling. No team ends polio without failing. Failure is part of the learning process. And so all of that is leadership dependent. Can it work? It definitely can work, but it takes context, not just method.
You know, this question about a good aim, I was thinking recently that, you know, just one could only conclude, looking at New York City's results, that our aim has been more shelter, more housing, more money invested, whereas in fact we need aims that are about less of what we don't want. You know, we want, we need to be driving to zero. We need to be driving to a place where families are paying a reasonable amount of their income on rent. And I know that in some of the huge undertakings, some of which we've completely copied, Don, like the 100,000 Lives campaign, it was really about, you know, saving, you know, avoidable deaths, saving lives measurably, so like fewer errors. And so in some ways that's very, you know, countercultural, that we want less of things.
Yeah, partly it's a confusion between aim and method. Mm-hmm. So when, like in healthcare, it's we need more doctors, we need more nurses, more space, more computers, more budget. More budget in a country spending 18% of its gross domestic product on healthcare when the next most expensive is 12, something's screwy here. So people confuse dosing the current structures with the goal. The goal is not more doctors, the goal's not even more healthcare. The goal is in the experience of the community and people we serve, what matters to them. And then in the improvement world, the world I live in professionally, you take this aim, hopefully through the eyes of the person you're serving or working with to serve, and then saying, what's the way to do it we haven't yet thought of? And that journey of redesign is key. It's design and redesign. So when you find when you find in general that the proposal is more, like you said, maybe that's right. Certainly in like extremely resource poor settings, there's a minimum you've got to be over. But no, most of the time we're trapped in the status quo. So the only thing we can imagine is more of the status quo. The improvement varsity don't do that at all. They're constantly confident that we can better meet needs with lower defect rates, much more delight, and lower cost. We just have to keep that journey, that search going. Again, I don't know how that plays in housing, but I don't think the purpose of fighting homelessness is building homes. It's people should be in good homes, good housing. I don't know what that looks like, but it's not necessary. It's probably not the status quo.
I think, you know, here in New York, I mean, we have more talented people in all of those. I think I must have listed about 40 different areas of our housing system. Like, we typically don't know each other. People who are, you know, working on planning don't necessarily know people who are working on affordable housing, who don't know people who are working on market rate housing, who don't know people who are working on homelessness and within homelessness. The housers don't know the outreach teams. You know, it's you know, talk about silos. And, you know, given the talent in this city, you know, I remember at one planning meeting, Emily mentioning, isn't it a shame we don't have a common identity, like we're all housers, or we're all people who are building the livable city, that we are in our zones to, you know, our diminishment and at great loss to what could be achieved here in the city. And I'm curious about this sort of appeal to the original kind of aspirations of the healthcare workforce, because people don't go into these fields just, you know, to dial it in. So
there's so much to your question. Where to start? W. Edwards Deming, who's one of the great scholars, he said once, I heard him say, aim creates a system. And what he meant was, tell me what you want to get done. Tell me what you're trying to accomplish. And we can together figure out who's part of the action. it won't correspond to any existing structure usually, especially if we have an ambitious new aim. AIM creates a system. Instead, what we have now is fragments creating their own futures. Paul Batalden is the source of the "every system is perfectly designed" quote. I think it was his idea, although I'm not sure. Paul once had an Israeli visitor who asked him the question, how can you spend $3 trillion on healthcare? Meaning it's so much more than anyone else is spending. And he said, Paul's answer was, it's easy, just create enough fragments. So the fragmentation is very deep. So how do you overcome it? You want what you said, which is people need to begin to ask the question, what am I part of? Who depends on me? There's a whole behavioral issue as to being seeing oneself as part of the same system. But then you need the table, and that I think is probably in healthcare one of our weakest links. Everyone's very busy. They're working as hard as they can, and when you say, let's have a meeting, they kind of groan. Well, how are you going to get to know each other? How are you going to figure out that we interact? There were 20 or 30 elements on that first slide you had up, Rosanne. How could they ever find themselves in a common space? Yeah. And you have to do that. You have to be together. And then, by the way, in healthcare's case, be together with the patient, with the family. If they're in the room, they'll provide some glue. They'll remind you that your little tribes are not helping them. Only your team is. So you need to be together, and we don't have time to do that. We don't have skills to do that. And there's a whole enterprise here of getting in a room and discovering how much we need each other on behalf of the people we help. It's partly a resource question. It's partly an attitude question, but you can't skip it. In healthcare, what's happened is the opposite. I don't know about housing, but I'm not sure this is at all helpful, but what's happened in healthcare under financial pressures and guilds and silos and external inspection and fear, what's happened is that people have regressed to their own fragment. They've come apart instead of together because it's safer to be in your own place, protecting your budget, protecting your space. So there's something to overcome here in terms of all of the enforcers of fragments.
Could you share a few stories about before and after, where you've seen systems make that transition and figure out how to align efforts and at least reduce friction and kind of deal with competing interests and kind of get past that?
Sometimes it's leaders. Sometimes there's a chief executive somewhere who has woken up and said that we're not going to make it. This is a survival matter, and unless we come together and begin to help each other, we're not going to survive. And you see these charismatic cases of a CEO who said, I remember one story, John Bingham was the CEO at Magic Valley Medical Center in Twin Falls, Idaho. John told me this story years later. A patient had been killed in the intensive care unit by an error, and so the hospital did an investigation, and John said he called all the people in the room, and they did the case investigation. He was the CEO at the head of the table, and he got angrier and angrier, and finally John said, he pounded the table. He said, "Who did this?" And then John, almost in tears, said, "I suddenly realized who did it. I did." What he meant was he hadn't created an environment in which everybody could take patient safety as a core mission and begin to work together around that with trust and affection and energy, and that he as the executive was responsible for that. Another really good example in healthcare, I don't know if it plays in how this will play in housing. So one way we screw up in healthcare is to give people infections in hospitals. And when I was training in medicine, sometimes you had to put it's called a central venous line. It's a plastic catheter that you feed through a vein into the heart to feed someone or in their bloodstream or to give them a difficult antibiotic. These are called central venous lines, and that's a foreign body in your bloodstream, and so sometimes they get infected. Bacteria love to glom onto it, and so when I was in training, many a night, I'd see a patient whose central venous line had got infected, which is terrible because then you have bacteria in your bloodstream, and that's sepsis, and the sepsis death rate is very high. So it was just part of the territory. People died. 1 out of X, I don't know what X was, maybe 20, with central venous line sepsis. It was just what happened. And then science began in the late 90s. Researchers began to see some changes that looked like it was possible to not have infections, which I would have thought was impossible. And this is a more detailed story. It turned out there were 5 changes you could make in the way you cared for the patient that it turned out eliminated central venous line infections. But nobody listened. It wasn't happening. So we organized the 100,000 Lives campaign. We weren't alone. There were several other things going on in the country. But we just said, hey, everybody, we can stop this, and invited people to get involved. And Rosanne, the energy was phenomenal. It's a little more complicated because we actually had 6 changes, but that was one of them. All over the country, people started to say, I can do that, I can do that. And our goal was 100,000 lives saved in 18 months. And we did it. More or less. We don't know the exact number, but there was a lot of lives saved. And I'll finish the story with this little anecdote. So my staff, young kids that were nobody over 30, who were running this campaign, I was CEO of the Institute, without telling me, they rented a bus and they shrunk wrapped the bus. That is, they put a logo, 100,000 Lives Campaign, and they drove the bus across the United States, making 15 stops for rallies. And the one that really gets to me every time I remember it is at Badger Stadium in Wisconsin, the bus pulled in, and there the hospitals of Madison had taken a segment of seats at Badger Stadium and outlined 2,000 seats with balloons, and told my staff when they arrived that that was the number of lives they were going to save. That's what improvement looks like.
Yeah. Your story, and we actually imitated 100,000 Lives by creating the 100,000 Homes campaign, but just to, that story of just, kind of an atmosphere where, people essentially are written off, like collateral damage to a system that doesn't really have an aim. I was at a meeting last week that someone at the UN had pulled together, and wisely had invited an incredibly thoughtful woman who had experienced homelessness here in New York. She's been housed in her own apartment for about 4 months. But she told the story through tears of being evicted for want of $251, being sent to a shelter, a mental health shelter, because she had a hip injury, and it was the only one where there was a bed with an elevator in that shelter, and begging for help, getting out of the shelter, finding housing, finally found housing on her own and figured out how to work the system. But she was in that shelter for 17 months. That represents at least $50,000 in taxpayer expenditures. And this woman who was just traumatized by the whole experience. So for want of $251 and a system that couldn't be responsive to that, this traumatic experience that was a disaster for everyone. But then to contrast that with the 100,000 Homes campaign, which was very much modeled on IHI's, like, who's in, and just, if you want to learn how to bring improvement science to the work of housing people who are experiencing homelessness, and we had, the goal was 100,000 medically vulnerable and chronically homeless people housed in 4 years, and 186 communities participated, housed more than 105,000 people without new resources. Really just by looking at people, what could we do? What can we be released to do with our intention, our passion for improvement? And it again made the point that sometimes it's the invitation and the context of permission that's missing. I'd love to know, because this quality movement you have driven in healthcare for so long, what do you see are the clear victories? I mean, now in all of these healthcare institutions, they learned how to do something institutionally that prevented avoidable deaths. What are some of the other ways that you're measuring progress in healthcare. Maybe to say a bit about the triple aim and how you've kind of widened your lens.
Well, it's a generous question because it gives more credit to healthcare than healthcare has yet earned. I'm testifying at the House Ways and Means Committee on Wednesday on Medicare for All, which is a very rough political position, but one of my motivations is we just not doing well enough yet because we're so fragmented, especially in payment. So I don't want to take credit for the implication of your question that we're there. We're not at all. But there are really good stories, and I think so some of the gains that I have to chalk up to the system over the past 20 years or so, one is we know there's a problem. There isn't any hospital, well, no, I wouldn't say that. There aren't many hospitals today that don't know patient safety is a threat. They don't know their variation is insane. They don't, and I even think, although they may not say it publicly, they believe that the costs are out of control. So it's like we have the first part of the problem, sort of, which is we know we better change. And we now have the National Academy of Medicine, National Academy of Sciences, Engineering, and Medicine, having been on the record about how serious our quality defects are and how excess our costs are. So that's good. Can't improve without an aim. The aims are available to us now. We also have this acceptance now to some degree of the scientific approach to improvement. That I wish it were more true, but I think most places, a lot of places now are believing we better use science to improve, that exhortation and blame aren't going to get us there. Probably overstating a bit because I don't know how many hospitals that's true of or how many health systems. Results are in a funny state. They're like, if you tell me a problem like infections in a hospital or waiting times or overuse underuse of community-based resources, I can tell you someone that solved it now. Almost every problem, we have an example somewhere in the country, and if not in the country, somewhere in the world, of a system at some level of locality that's really, really made progress. I've mentioned the central line infection. We had 53% decline in central line infections nationally now, but not 100. So that's good news. Where we're stuck is spread, is finding out that they really now have really nailed it. Kaiser Permanente, Northern California, 95% of the diabetes care is now administered by pharmacists. Better results than the normal diabetes system. 50% of their visits are virtual. It works. Better care, better health, lower cost. Why can't everybody do it? And we're having devil of a time spreading the changes around. So I guess locality-based improvement, good news. General improvement, we're still got a long way to go.
That raises, I think, another really vital question, Don. One of the things that IHI has always operated from is sort of voluntary participation. You care about quality, you're in. We'll work together to figure this out. But then, that was your perch at a not-for-profit that was trying to drive this new idea in the field. Then you went to CMS and had your hands on some levers of power and the idea of like compulsory, improvement. What did you learn about the benefits, the hazards of both approaches, and where do you come down on it now?
Yeah, IHI's strength has always been that we have no power at all. The only mechanism we have is invitation, and it's just inspiring to see when the invitation is issued, how many people show up if you can issue it in a trustworthy way. Yeah, then I went to CMS. So President Obama appointed me head of Medicare and Medicaid. He was a recess appointment, and the Senate refused to hold hearings. So I was administrator for 17 months because the Constitution limits the duration of a recess appointment. But I had a year and a half to do my thing. So what did I find out? First, government doesn't, it's a hard place to do improvement because everyone's scared. The media are watching you. The oversight committees are in full flower. Your opponent is redacting every word, is studying every word you say. So there's like this hunker down. So when you try to be bold or invitational or take risks of failure, there's a job to do, which is to help people in government accept that you don't succeed without failing first, that bold goals help, that public transparency is a good thing. But I found things quite ready. I mean, the workforce was ready. We had 5,500 employees in Medicare and Medicaid. They had not had an administrator for 6 years, had been vacant. And they were, but it was wonderful. They just couldn't, they were so inspiring to take on goals. So I found them, like any workforce I've ever worked with, ready to roll. But the government's tools tended to be the sharper edge, you know, requirement, punishment, reward, incentive. And I think they were weak. They're weak and blunt tools. I administered the law. For example, the Affordable Care Act required that we publish rules for when hospitals will be penalized for medical errors. We did it, and I think hospitals, they woke up a bit more. But I came back more of a fan of invitation and attraction than I ever was. If you think you're the boss, you're wrong. People will end up doing what's sensible to them. The flip side of it, I think, does apply to housing. Is that said, in any regulatory environment, you can have a bunch of toxic rules. With good intention, you can be doing things to people that keep them from flexing their muscles, keep them from taking risks. And I think there's a whole agenda here towards sensible regulation, which sets minimum standards, which the public has to rely on, and you have to enforce those, and then creates an environment, a permissive and encouraging environment for learning in the real world. And I think we got a bit of a gap there in healthcare. Too much requirement, not enough encouragement.
You mentioned incentives with like a kind of a dubious tone. Are there incentives that actually you find powerful and incentives that you thought would be significant that turned out to be toxic?
A lot of lessons. I wrote a paper which you'll have trouble finding unless you Google it, but it's called The Toxicity of Pay for Performance. And it's my cri de coeur about how awful individual pay for performance is in almost any environment. I don't know why it's so hegemonic, why every leader, every corporation seems to believe that we have to have these complex payment schemes which give 5% of the people a raise, reward, and others a little bit, and then dings others. It's just wrong. Most of the variation in individual performance is being induced by the system in which people are working. And if they're heroes, they're going to be heroes without a reward. And if they're going to be dopes, they're going to be dopes without punishment. You have a job to deal with that. But I think individual pay for performance is a terrible idea. And good luck in trying to stop it, because it's everywhere. At the group level or the corporate level, I have a little different idea, which is I think we have to set goals and then, like zero homelessness, and then say stuff about the organizations that are contributing to those goals and the ones that are hurting them, and use economics to do that, use publicity to do that. I think when we're talking about the entity level, I'm for it. The other point has to do with the burden of measurement. So skip individual pay for performance. Let's use it at an aggregate level. What I did at Medicare under the terms of the Affordable Care Act, we had to publish a lot of metrics. Like, we started a program called Accountable Care Organizations, which I won't bore you with, but this is an experiment with value-based payment, and it rewards groups for coming in below budget, basically. But that's dangerous in healthcare. You have to make sure that patients aren't getting harmed. So we have mitigating metrics that said, yes, you came in below budget, but your quality went up. So we ended up publishing 32 quality metrics, which were the surveillance tools to make sure that these organizations weren't skimping. You know, I worked really hard to get those right. They're pretty good based on science, but I think it was too burdensome. I think we ended up burdening the system with all this reporting that is taking energy away from doing what they want to do, which is take care of patients. So there's a balance to strike between the amount of measuring you're doing for incentives and the distraction and the cost that results in. So I made a public call 2 years ago. I said, we need to reduce measurement in healthcare by 75% in 5 years. we're just killing the workforce, and they're being demoralized, and plus it's a game. It's not about purpose, it's about the numbers. So I guess I'm much more moderate about it. We need just enough measurement.
Mm-hmm. Since we're on measurement and data, how, I mean, I'm thinking in our universe of housing here in New York, and frankly in any city, I think it's much more achievable to know if you're actually getting closer to zero homelessness. Harder, it's right now we just have these periodic American Community Survey tools to find out rent burden, but there are some measurement processes out there that would help us if those are our collective aims. But the idea of making data public to the public, citizens as, I know you don't like accountability, I kind of do, but citizens with the information to know whether, where we want to be as a community. How does one get at information in healthcare about whether a hospital is on its game, or a healthcare system in terms of doing everything that you would wish for them to do from a cultural and a belief standpoint about patient safety, and just how might that publishing results and some measurable commitment help in this quest here?
Well, I love the focus of nobody homeless and nobody spending more than 50% of their income on rent. I would definitely go for that, and I think that's the kind of parsimonious, frugal, important measures that I would go for. And in terms of public transparency, I am all for it. I don't think there should be any secrets. I think whatever we know, anyone should be able to know. So I'm all for that. Not particularly because the public then gets so energized and becomes smart consumers. That actually doesn't seem to happen much. It's because the production system, the workforce, they become embarrassed or happy. It gets juices flowing in a good way. So I'm for it. Mm-hmm. But the message I'd like to suggest is to distinguish between what I'll call outside-in measurement. Let's measure these things so people will feel accountable. And inside-out measurement, which is like my grandson needs to know where the ball went when he swings the bat. So the outside-in stuff is very expensive. It is definitely going to induce games. It's necessary, and in the end, I want to know how are people doing on the rent stuff. So we should have that to some degree. But what's really going to energize the improvement work is the measurement that, at least in healthcare, that a workforce, that the operating room team or the ICU group or the infectious disease unit, it's the team's knowledge of how they're doing, so they can get better. It's like, where did our ball just go? Yeah. And what happens is when you have all this top-down enforced stuff, everyone's playing this upward game. The measurements, by the way, become, they're like going to the moon in timing, and like you're never going to see the result for 6 months, or the report comes back and you're not quite sure what it means. It's not the same as swinging the bat and seeing where the ball went. So in the world of improvement that I'm in, I want metrics, but I want metrics at the local level, under local control, with local units learning how they're doing. Sometimes, if you're really smart, and my colleague Brent James, who you may know Brent, he argues that if you do that right, you can roll that up and get the other stuff you want. The mistake we made in healthcare is we've got like 95% top-down for 5% local use, and we did the opposite is what matters. How that plays in housing, I don't know. I mean, I just don't know how that would.
Well, I have an example. Let's see. Yeah, that was it. This has been the game changer in our Built for Zero communities, and it took years for us to figure out, working with these really amazing volunteer teams in all these communities, that you couldn't tell if you were getting closer to zero homelessness if you didn't know by name in real time who was actually experiencing homelessness, with enough information on each individual or household to know what it would take to get them out of that situation. And this, pretty simple system dynamic dashboard that is produced by the local teams that tells them, they hit the ball, where did it end up, where do they need to move next? has been really revolutionary. So communities are looking at least every month, often every week or day, at how many individuals are actively homeless, and then looking at who is new into homelessness, and the number is never so large that they can't actually go and interview those individuals and find out what happened, that, you know, where the upstream fault lines are, and who's returned to homelessness either because they'd been housed but something went wrong with that placement, because that's a different problem, a different improvement project, and who has returned to homelessness after being off the radar screen for 3 months, because one of the things we never really knew how to account for was the fact that most people who experience homelessness sort it out themselves. And so some way of seeing, what I'll say is seeing the system whole, you know, people who are right in front of you, breaking that down into, you know, how people came into that situation, and also looking at how many people you placed into housing, how many people have kind of disappeared, and the assumption first is that they have sorted it out themselves, but you don't lose them in the tracking should they reemerge. They haven't lost their place in line for assistance. But just this idea of having the right information so that you can see the system whole has been so powerful in terms of helping local teams know where they're making progress, where they're stuck, where the most significant leverage points would be to actually create a small test of change and apply the PDSA cycles. And so this kind of information on homelessness we see is what can revolutionize the field. And one of the questions we're asking is like how to move it upstream and also how to spread it. Right now, it's totally voluntary to have this kind of you know, grasp of reality.
Well, the spread I can't definitely help you with. I'm struggling with it too. When you find out, let me know. It is going to depend on a lot on leadership. I love this. There's two things about it I would highlight that are I find so attractive. The first is the N of one idea, that these are names, these are registered individuals, and whenever you can get to that point where everybody has a name and a story, and you can think at that level, I think you stand a chance for advancement that you otherwise are not going to be able to have. So this idea, and that leads to the second idea. You use the word local. So this is both an answer and a question, which is, I guess the question is, at what level of aggregation are we going to be most powerful in achieving the gains we want? In a nation with a Congress and a presidential race, and you tend to think, oh, it's what happens in CMS or in Washington, and that's important. That's a very big, important context thing. But when you actually look at improvement, there's a locality nature to it. So in healthcare, how they fix infections at a hospital in Umpqua, Oregon, or in Harlem, that's not going to be the same. And you need local ownership of all the changes, all that learning cycle. It's going to be local learning with general principles and local learning. I don't know in healthcare what the size is. Probably a hospital is the right size for some of it. But when we're talking, for example, in healthcare, a big topic now is social determinants of illness. And I won't, we could spend a long time on that, but they're immensely powerful. Things like housing, or transport, or nutrition, or physical activity, or violence in the streets, or racism. These have effects that overwhelm anything we ever achieve with a medicine or an operation. Overwhelmed by 10 or 20-fold. And yet we don't work on social determinants, not systematically in this country. I haven't seen it. We can't work on them as a country. That is, it would be very hard to think about. We could set aims, but the work has to be what, where. In Cincinnati right now, very interestingly, Cincinnati Children's Hospital Medical Center has said, there are 60,000 kids in Cincinnati in positions of disadvantage. There are people. And we are going to provide a common table to pull together actors throughout this community to increase the well-being, and there are specific definitions of those 60,000 kids. That locality-based work, I'll bet on that a lot compared to anything that's going to come out of Capitol Hill.
In fact, we met Uma Katagal and the team at Cincinnati Children's through IHI, and one of the things I think characterizes the great kind of systems work you see beginning that's very local is the ability to see assets, not just problems. like, what aren't we deploying? What strengths do people have that we need to recognize instead of everything's pathologized or everything is just a problem for the professionals to solve?
That's related to your earlier comment, more. Mm-hmm. It's turning out in healthcare, and there's some really exciting stuff going on now that patients and families can do for themselves, things you never, ever would have imagined they could, that we require them to come into the healthcare system to do at their inconvenience, with extra risk, extra cost, when they're very happy to take it on. We've just stood in their way for all this time. The abundance of the capacities, in that case of patients and families, is overwhelming. And you look at community resources for addressing upstream causes of illness, they're there. Interestingly, and I don't know how this applies to homelessness, I have seen this, I've learned a lot of this from looking at low-income countries. I've worked in Ghana, in Ethiopia, in South Africa, in Malawi, and when you go to KwaZulu-Natal, rural KwaZulu-Natal, dealing with very complicated problems, say of HIV treatment in places that don't have any doctors, they invent their way to all sorts of new ways to do even better with other assets. And so that asset-based thinking, I think, is crucial in healthcare, probably in housing too.
Very much in housing. And when you think of, like, what have we thought of all of those actors in our housing system, all of these folks we are connected to but don't recognize as assets in getting to clear aims for a housing system in New York. It really goes to something that has, for the longest time, seemed both puzzling and hopeful to me, that I think like healthcare, housing, social welfare services in general, we're kind of the last frontier of knowing that these are solvable problems. When you look at, like we touched on earlier, manufacturing, aviation, even most supply chain management, like they're using principles around problem solving that are so relevant to the kind of work that needs to happen, and really sort of anticipate kind of human error and make it less likely that we'll be harmed by it. What are some of the inspiring stories out there, Don, that you think could actually, they've been relevant to you in healthcare and that we could begin thinking about as they apply to our housing challenges here?
Well, a couple. One is maybe your story about what looks impossible becomes possible. One of the breakthroughs in healthcare has been the invitation for non-healthcare people to get interested in and curious about solving some of the problems we live with. Patient safety is a great one. As I think you said, or you said, I can't remember, we learned in IHI so much from just putting our white coats in the closet and going out and meeting with NASA and manufacturing companies and aviation and nuclear power you mentioned, about how do you get ultra safe? What does that look like? And the striking gold is they want to help. They're all too ready. Then they can say, oh, where can I come? How can I help you out? So this cross-sectoral generosity is out there. That's been really cool and very important in the progress we've made. Another I already mentioned, which is the limitless importance, limitless potential of having, in healthcare, I guess we'd say the patient in the room, the customer in the room, maybe the homeless person in the room. They know the answers, at least in healthcare they do. The patients and families know much more than we do, the providers, about what actually would matter. Mm-hmm. And interestingly, often the solutions they come up with are cheaper than the ones we thought were necessary. So this kind of opening the door, I've given a lecture on changing the balance of power. That's been profoundly important. And to see a team now with a patient and family in the room inventing new healthcare has been tremendously exciting. The other thing we didn't talk about yet that I think is part of the answer, maybe it's too far from your question, but I don't care. It's the moral side of it. A lot of this is technical stuff. Healthcare is finance-driven. It's quite a technical enterprise. Science is there and all that. But I'll tell you, I think one of the most important things that happens in the healthcare world is to recover the moral vocabulary. In my case right now, it's healthcare is a human right, damn it. It is, and we have to be willing to say that. And it's not okay to take 18% of the money from our economy and waste a third of it. That's not okay. That's people, that's schools don't get that money, and roads don't get it, and corporations can't use it for investment, and people can't take their kids to the movies tonight, and that's not okay. And that ability to work from a framework of what we owe each other matters. And the good news is, even in a country right now that is viciously and unacceptably led with a vocabulary of loss and anger and difference, when you go to the community level, people, I think the moral tone is, it's there. It's there. People want to be together, and so that's one of the secrets of improvement.
I couldn't agree more, Don. And you know, it's always been interesting when I'm out with my colleagues, with these community leaders who are just getting the job done and have learned how to work differently as teams and know people by name. And when they are celebrating getting to zero, they're thinking about all of these lives that have changed, but they're the ones crying because it's like, this is what they signed up for, to make a difference in people's lives, and they have kind of recognized somewhere along the way, and it's kept them going against what seemed like mission impossible at the outset, but that this is really more about them as a community than about like the technical details of how you do problem solving in this environment. So I do think it's an invitation to kind of I don't know, just be the communities that we wish to be part of, and be the servants of each other that we signed up for, and doing this work in the common good.
I think the will is there. When early in the work of the 100,000 Lives campaign, one of the things you're working on was ventilator pneumonias. When you're on a respirator machine, you can get pneumonia from the machine. But just like central line infections, we now know how to eliminate them to zero. And there was a hospital, I can't remember where it was, that I think they'd gone about a year without a single ventilator pneumonia. That was like one of those things, if you told me that 3 years earlier, I would say, that can't be done, but they did it. And I remember getting a call from the operating leader of the intensive care unit, and he said, Don, I'm just calling you to tell you that we had a ventilator pneumonia now, after a year of zero or something like that. I said, oh, gee, Randy, what did you do? And Randy said, well, first, we all sat around and cried. You talk about incentives and rewards and punishments and pay scales, and that's that intrinsic will, pure gold.
Yeah. I'm going to invite some questions from the audience, but is there anything else that we didn't cover, Don? And I'm tempted to say, if you were just put in charge of designing a system, what would the kind of the pillars be?
I don't know for sure, but I was mentioning, in the World Health Organization has a marvelous set of documents now, guided, I think, by a colleague of mine named Ilona Kitbush, who's just amazing, called Health in All Policies. And it's a firm recognition of the interdependency of the health-generating properties of communities. And it says you can't leave health to healthcare. You have to have health in all policies. How will this transportation decision, this housing decision, this defense decision, this environment decision, all will affect health? And so you begin to see health as a resultant of interdependent activities, health in all policies. So I guess there's homes in all policies too, which is how will everything on that graph, how will it make sure people can sleep tonight in their own bed with a roof over their head? And I think that in all policies idea is really good. And I think that goes back to political leadership in both of our worlds. You need leaders, and I'll say from at all levels of government, and I think it applies in the private sector too, who are going to say, well, everyone come around the table, we're going to do this together. And here's a kid in the middle, and that kid's going to have a roof over his head. And that's the key, that kind of convergent, that table you showed. I think it really, really matters, and so it's the platform question, and that would be the number one task. When I was at CMS, I'm not taking credit when I can't, but one of my aims was to make it one CMS, one system, and I said we're going to operate with 5 values here. I did it from day one. Every speech, every time I met with the staff, it was boundarylessness, speed and agility, unconditional teamwork, innovation, and customer focus. That's going to be how we're going to do our work. If you don't know what to do, check that list and it will tell you how to act with each other. And that insistence that we're in it together, to me, is crucial.
Does that have to come from a single sort of designated leader in this fragmented, non-aware system? Where can it come from?
If you got one, use them, or her. Yes, that's the best answer. When it's too fragmented and there is no leader, I don't know what to say. Charisma. I mean, you've done it. You called your first. You said common ground. That's what you named your effort, wasn't it?
The first one. Mm-hmm.
Yeah. So why did you say common ground? That's exactly what we're talking about. What did you have in mind?
I think everything we're talking about. But I think at a city level, you spoke as a hospital as a unit of change. If we're thinking about our city,
Yeah.
Do you have observations about where surprising sources of leadership have come from?
I think a sector can. I think that healthcare is pretty trusted, and I think you could have healthcare leaders say, "Hey, everybody, we're going to set the table." The mayors, obviously. I mean, there is a city structure. I wonder where the corporate leaders are. Would it be possible to have a business roundtable or a business labor roundtable say, "We're going to take this on and stick with it for a decade"? Mm-hmm. It can come from a number of sources, but it has to come from somewhere. People want to work together, but someone has to set the table and invite them to the table, I think.
Don, thank you. Let me just see if there are questions from the audience at this point. Yeah.
Just taking your last point, what if that leadership isn't there and there's a key player in your system, which just doesn't share the goal? What's your strategy? That happens.
Well, if it's an elected leader, elect someone else. And there is a need for an informed public to demand leadership on the things we care about. When you're in an executive position and there's someone key that isn't with it, you only have two choices, in my view: end run, make them irrelevant, or fire them. And I teach my students something that may not be responsive to your question, but it's run from every fight. There's enough will to get the job done that if there's a bystander person or someone that is just not with it, try to make them not relevant. I don't know another way to say that. One of the very hard jobs in leadership is when you want to lead for systemic change, and there is somebody, especially in a key position, who isn't able to do that. They need to have a different job, and I think that's a kind of discipline. When you're lower down in the hierarchy and it's someone above you that's in the way, it's very, very tough. Dr. Deming used to say, "Leave, go to some place where you have an opportunity to do it." I don't know what the right answer is. At this moment, I think that we're in a very tough place in the country where we seem to be electing political leaders who are divisive, who would rather create winners and losers than solidarity. And I think there's a political arm to the political side of this, which is we need a public that's mobilized for solidarity in a way we haven't been for a while.
Kind of a related question. Do you think part of the reason that some of these leaders have been able to make such change is because the job is stable? It's because it's like a comfortable job in most cases? Do you think that's a requirement for getting a good leader in place for a system as complicated as this?
Yeah, I'm not sure which of two questions you're asking. One is, again, Deming. Deming's one of the great minds in the field, so I keep quoting him. He's didn't write the Bible, but he wrote a lot of good stuff. So Deming believed that in the systemic work that Rosanne was talking about, rapid turnover of executive leadership he called it a toxic, it was a toxic thing. You really need some longer sight here. And so, yes, often the changes that are starting to occur are in the hands of someone who's just sticking around for a while. 5, 10 years of leading toward a vision we're headed for. And I think the rapid turnover is really a problem. In American healthcare, the turnover of, for example, corporate executives, CEOs of hospitals is a little too fast. The opposite can also be true, though, which is sometimes longevity represents a vested interest in the status quo. I'm doing just fine, thank you. You know, my income's high, my board supports me, I'm in a stable view, why would I rock the boat? And the fact that there are 400,000 people that don't happen to have
Or paying more than 50% of their income in rent.
is not enough energy to rock the boat, and that's bad too. You know, there is a commitment to change here. If Nathaniel or Caleb, my grandson, will never be a better baseball player if he keeps doing the same thing. And you need leaders who are uncomfortable, not comfortable.
Yes.
I want to challenge you a little bit on accountability. I think maybe in healthcare there is much more of a sense of connection to individuals who are victims of a system that is faulty. But in housing, I think when you look at the 40 organizations that are so disparate, I feel like there's on multiple levels. It's almost everyone knows somebody who's ended up in a hospital at one point. Not everyone knows somebody who's been homeless. And while you might see them on the street every day, we might sort of feel very disconnected from them. And then I think political leaders, all the different people who are powerful in the system, the more powerful they are, the likelihood that they feel like they bear a responsibility. The idea that the mayor of New York might want to sort of have a ticker, showing the number of homeless people going up and down in the city on his desk. Like, to me, that is where you want accountability to to get those people to really feel the need to help move the needle when they could muster a massive amount of resources.
Yeah, thank you for that. I agree with you. And at the aggregate level, yes, I too want a ticker, like you put it on the mayor's desk, saying, here's this morning how many people were paying for more pictures of the rent or homeless. I think that's important, and maybe that's what accountability means. Kind of, if you have a goal, let's know if we're getting there every morning. Paul O'Neill, who was Secretary of the Treasury and before that President of Alcoa, every morning got a report at Alcoa on the number of workers injured in the previous 24 hours. It was one of the first reports he looked at every day, and everybody knew it. And Alcoa became one of the safest companies in heavy industry ever known. So I'm with you on that. The problem with accountability, and I guess I'm being a little too fussy about this, it has to do with misunderstanding the motivation of the workforce. I don't know what it's like in housing, but in healthcare, most people, most of the time, are showing up for work to try to get a good job done. They would like to be proud of it. And the concept of accountability is a kind of misunderstanding. It's like, I'm going to hold you accountable for doing a good job, sir, and if you don't, you'll get punished, and if you do, you'll get rewarded. That produces a dynamic between the people actually doing the work and the people leading that is very, very bad. Yesterday's New York Times had a wonderful essay by Dr. Ophir, I think her name is, from one of the hospitals here in town, and she wrote about this idea about what the workforce in healthcare is really doing every day, what they're really trying to do, and it's a beautiful, almost poetic, and I think quite correct piece. So I agree, I got to find a word that isn't accountability, which shows that I agree with what you said about what's on the mayor's desk, but would challenge you to think about how we're treating a workforce that's trying pretty hard to do the right thing.
Yes.
You spoke about inside-out metrics versus outside-in metrics.
Yeah.
And how the inside-out metrics are more valuable towards actually achieving.
For improving, yeah.
Exactly, right? But you also mentioned this challenge of being able to disseminate information in order to have improvement over a larger area. Is there, I'm not sure if there's a solution, or have you seen solutions in being able to apply those inside-out metrics across multiple localities?
Yes, yes. Well, first, so let me just clarify this spread problem versus the local improvement. With anything you do that you're trying to make better, like hitting a baseball or cooking chocolate mousse, there'll be a recipe book. That is, if you're doing it right, there are going to be some principles. You'll read to your child, or you'll watch Ted Williams swing, and there'll be some principles. We call those change concepts. That's the term IHI uses. I don't know if you
We
picked
call
that
it
up.
change packages.
Change packages. This is the basic scientifically or experientially grounded idea at some level of generality. When you actually watch improvement occur in a child or a chef or a marriage, the general, hopefully they know some of these general ideas, they've gotten to them, but then they make it their own. And the way everybody does it is a little different, and it better be, because you're left-handed, I'm right-handed, because it's hot today instead of cold, because we don't have that kind of bat around, or I didn't have the right chocolate. So you always have to adapt locally. So local improvement is a very sweet enterprise of local use of general knowledge. So the top-down part is accumulating the general knowledge, and the bottom-up part is adapting it to your local setting. That's how it works in healthcare. The same 5 principles for preventing a central line infection are operating, if they're working, in Twin Falls, Idaho, and in Columbia Presbyterian. It's the same 5 principles. They're going to look very different in those settings. So that's the connection. Now, you went to measurement.
Doesn't that need to loop back around?
Yes. What do you mean loop back around?
If you have those change principles and they are disseminated out, but then they are localized based on local conditions, shouldn't the results of the local conditions go back up to the top as a creating feedback?
Yes, for learning purposes, because if Columbia Presbyterian invents something that you didn't know when you set the principles, it can modify the principles. So there's a big learning loop there, yes. I thought you meant for accountability purposes. The more general idea would be, well, we have to measure what everybody's doing so we can reward them and punish them, and that's where I'm not on the bus. Yeah, but you're right, that there is a virtuous cycle of local innovation that will feed back. I'll give you one good example. It turns out a lot of cardiac arrest could be averted. That's in hospitals, and the basics are that it turns out that before someone's heart stops in a hospital, which is then a code blue and everyone comes and the success rates are very low in resuscitation, like 10%. It turns out that when you look at it carefully, nurses and often visitors, family members, know something's wrong long before the heart stops. And I don't know how they know, but they're picking up stuff that they can't even put their hands on. So a worried nurse is actually a very important indicator that something's going to go wrong. Well, I didn't know that until some guy in Australia who happened to be the head of intensive care unit began to work with that and develop what are now called rapid response teams, which is you have a code blue, but it's triggered by a worried nurse, not a stopped heart. And the initial results in Australia in the hospital where those tried were unbelievable. The number of decreases in cardiac arrest was phenomenal because they were working upstream on whatever was going wrong with the patient. That came from one place, one guy, one town in Australia, picked up by our colleague Carol Harrod. I don't know if you ever met Carol in IHI. She brought it back to Boston. 3 years later, it was a central plank in the 100,000 Lives campaign. It became a principle, but it came out of a local unit. So sometimes what's happening in local innovation can be amazing if you're smart enough to spot it.
Jonathan?
Medicare for all. What's your position?
Can I go? I favor it. It's not easy politically. I wouldn't fall on my sword politically in this cycle. But right now we have such a complex payment system. It's driving people crazy. Doctors are now estimated to spend 2 hours on paperwork for every hour they're spending with patients. That's a study by Krasinski at the AMA published last year. It's insane. There's no accountability. Like, on whose desk does the ticker go? For housing, it's de Blasio with a ticker on his desk. Who it is for healthcare? Who's got the ticker on their desk for safety? At CMS, I was responsible for the care of 100 million people, 50 million in Medicare, 50 million in Medicaid. And my brother, when I took the job, he sent me a plaque from my desk in Medicare, and it said, "How will it help the patient?" And that was the plaque in front of me every day. So I was accountable. Opacity, you want accountability for costs? try to find out the costs, the internal costs in the insurance companies today. Try to find out who's paying what to whom. You can't. You have a beef, you think the country should be covering mental health services more generously, who do you bring that request to? I think with a consolidated payment system, and it has to be governmental, there's no other way to do it, we can achieve accountability, lower administrative burden, much more transparency and responsiveness than we are with this current system. And we're driving ourselves off a cliff with costs right now. So yeah, I've come down in favor of it. And I'm probably not supposed to say that in a 501c3. But
At CMS, I think one of the things you probably, I know from reading that you dealt with was trying to reduce regulations, and this is a related question to this. So we have the zoning code in New York, all 1,700 or some absurd number of pages of it. How do you engender the kind of bravery in
Yeah.
whom to take on those things? Because everybody's afraid that things will just get worse if you try to reform the zoning code.
I don't know what the story is in the housing or zoning codes, I can guess, but I'll tell you the story in healthcare. So we have too many rules. And when I went to Medicare, sort of on a lark, so a responsible lark, if there's such a thing, I set a goal for my staff. I said, shortly after I got there, I said, I want to stop stupid regulations. So find me 50. This was the people administering the regulations. I said, please bring me back 50 regulations. And they grumbled a bit, but they were kind of excited about it. And in a few weeks, they came back with a list of 100. Mm-hmm. They hadn't stopped. I mean, every regulation had some pedigree that was at one time sensible, but it became not sensible. So I became much more aware of the burden of these regs that we can stop. And yeah, everyone was worried, we stop this nonsense will happen. I think I'd rather take them away and then add them back if we need them, because we're just driving people crazy. Don't be dumb about it. If a regulation, I think probably hospitals should have fire extinguishers, so I'll keep that one. But so you have to be smart about it, but I think people can be smart about it, and I think a big enterprise like that would help in healthcare. So one of the things we do, which may be quite relevant to housing, I work at the Institute for Healthcare Improvement still. I'm senior fellow and president emeritus, and I have several assignments, and one of them is to run or oversee a network called the Leadership Alliance. And what we did is this. We took the so-called triple aim, which is a statement of goals. What are we trying to accomplish? The triple aim in healthcare is better care for individuals, better health for populations, and lower per capita cost through reduction of waste. Better care, better health, lower cost. That's the triple aim written about by Tom Nolan. And we went out into the world and said, okay, anybody out there, you want to work on the triple aim. It's going to mean fundamental redesign. Your current system is completely incapable of achieving the triple aim, but we can come up together with one that is. So 40 organizations signed up, and now that collective is 5 years old. There's been some turnover, but it's about 40, 45 organizations seeking the triple aim, the Leadership Alliance. And it's got a whole bunch of redesign principles, 10 redesign principles that we're trying to redesign for. One redesign principle is move knowledge, not people. Get care as digital as it could be. Another redesign principle is change the balance of power. Put patients and families back in the driver's seat. Another redesign principle is make it easy, which was take away stupid stuff. So for Make It Easy, 2 years ago, we launched the Breaking the Rules for Better Care campaign. We said, go to your staff, go to your patients, go to families, and ask them to identify a stupid rule that stands in the way of care. 24 of the 40 organizations signed up. In 1 week, 24 organizations, polling their staff, patients, and families, identified 360 stupid rules. And they were stupid. 85% of the rules were not regulations, statutes, or legal requirements. They were only habits, myths, beliefs, and administrative prerogatives. And we had the most fun. For the next month or two, everybody was told to break the rule, as long as you didn't go to jail. And it was one of the most buoyant, exciting experiments we ever did. I'm convinced we have really tied handcuffs. And remember, I'm not a libertarian. I'm on the left. I believe in strong government, but I believe in smart government.
Yes.
So I think you were pointing out something that I've been wondering about a lot, not just healthcare, but also in housing, is the fact that we have a lot of power structures, and often we're highlighting leaders here, like great leaders, but what really gets the work done is often seams. Like you were highlighting earlier, like aviation is a great example of like multiple people like providing like checklists and making sure that like we're ready for takeoff. So that being said, how do we actually start shifting a lot of these, you know, power structures that are present in an already fragmented system, both in housing and healthcare, like in a way that
Yeah.
one doesn't like push that fear of survivorship that often happens when people are in a position of not for a long time, but also like recognizes the fact that these incentives that we have, like, these values, these morals, like they will help us like, along, like down the long term.
You know, there's no simple answer, and you know, people in power want to keep power, but I think a couple of lessons is, first, results will matter. If we have the right kind of accountability and transparency, believe me, when you start to harness the wisdom of the workforce, and even more the wisdom and energies and abundance of the patients and their families, you will get better results. Your costs will fall, and your quality will go up. And to the extent we have transparency and are goal-directed, I think in a way the results may help. They may speak for themselves. A second is training. When I was trained as a doctor, I was trained to be a hero. It was my patient. I had to do it, and the buck stopped with me, and all of that's sort of true. But no, I'm not the system. I'm a citizen in the system, and now, if we could migrate medical education to have doctors be more sensitive to the interdependencies, that would help. Same for executive training, which is, you know, the stuff I'm telling you about, that can be part in the preparation of leaders, and we're working at that. In IHI, we started the open school for health professions. I don't know if an open school would help for housing. The open school, we couldn't get the medical schools to change the training of the young professionals. It's a little bit easier in nursing schools, but not that easy. Pharmacy, health administration. So we started a virtual school 10 years ago called the IHI Open School for Health Professions. You can find it. It's ihi.org/open school. It's free. And we populated it with, now I think there are 34 short courses on improvement. There are now chapters all over the world. Now, 10 years after starting that, we're now at 900, I think it's 950,000 young professionals are linked in this open school environment. We've downloaded more than 3 million courses. They've downloaded more than 3 million courses. We have over 900 chapters in now, I think, 97 countries around the world. It's this vast youth movement to learn the perspectives and attitudes and, I guess I'd say, humility that will underlie proper improvement. So I'm an optimist about this. The people are ready to learn it.
Yes.
Really like the point you were making about sort of devolving to the patients, if you will, and putting them in the driver's seat.
Yeah.
And I'm always curious how much accountability patients should have in this process as well. You know, when you go into a doctor's office or you go to a hospital, oftentimes you're not really aware of the procedure, right? What's going to happen? There's no real baseline. In the same way, perhaps, if you're experiencing homelessness or a need for housing, you're really unaware of how to navigate that system.
Yeah.
I think of the Organization for Urban Pedagogy, for instance, and all the work they've done to sort of push information out to people in ways that are sort of, I don't want to say more general, but more easily consumed, less professional. And I'm curious, you know, what work has to be done on that front, both in housing and in the medical field, so that when you have people coming in, they can act as advocates for themselves
Yeah.
and not simply be reliant on the system to catch them every time, right?
Yeah, great. I love the question. I mean, again, there's that word accountability. I don't know quite how you're using it, but it's like it's opportunity. In healthcare, for all sorts of reasons, largely the payment system, we take away self-efficacy from patients and families. They can do stuff for themselves, but we get paid to do it, so we do it. You know, if I get admitted to the hospital, the first thing I'm going to do is take away my pills and then give me their pills, even though I take those pills every morning. That's the reasons are sociologic and economic, but it turns out when you create systems and processes that support people to actually take on some stuff for themselves, they generally, well, the ones that can want to do it. And it's been we that's been in the way. And so it's not again, I know you didn't mean this, but there's some finger wagging around this, like, you're responsible for your own health. I'm not. You're responsible for your health. And I'm not for that. It's like, here's an opportunity to take over something that you really can do for yourself. I wish I could show some videos here, but the one I would have brought is a video of Zach Wohl. Zach was 9 years old when he made the video. Zach is a kid with Crohn's disease. He's malnourished. And so every night, Zach needs a tube put into his stomach through his nose, and then overnight, some nutrition drips in, and that allows him to live and to thrive, in fact. And what Zach did, because he's at Cincinnati Children's, which is an improvement organization, he learned to put in his own tube every night, and he takes it over, he does his own feedings, and then he made a YouTube video for other kids who might need to learn to put in their own tube. And here's Zach Wohl, 9 years old, training you to put in an NG tube to feed yourself overnight. He's an example of the future, which is, I can do it. He says in the tape, I can do it. And then he said, you can do it too. You ought to Google Zach Wohl and look at that. We've stood in the way a long time. In housing, I don't know. I'll tell you this, I suspect homeless people know a ton about homelessness and probably could help invent some solutions that people that haven't had the lived experience wouldn't think of. So there's a crosswalk.
And I'll tell you, one of the necessary steps we've discovered is getting the organizations aligned so people in different organizations actually can create a seamless system of assistance. One of the things that was just eye-opening, to say the least, was bringing community teams together who often were just in different parts of the system, like the VA, the Housing Authority, and asking them, with an individual experiencing homelessness in the group, asking them to map out what was required for a single person to move from the street to a home. And they almost couldn't do it. Yeah, on average, it took teams, and we did this in a number of cities, like 3 hours to even figure out what are the steps and what are the requirements and what are the places that money or contracts have to change hands. And it would be going on for a year on average it would take. And of course, the person experiencing homelessness would say, that might be what you think, but this is actually what happened to me. And then we asked the same group, what should this system look like that anyone could navigate? The person experiencing homelessness, any worker from any of your organizations. And it took on average about 12 minutes to be like, well, if we really were serious about this aim, we would just do this, this, and this. And then actually to a point that Don referenced, we asked the same group, what is keeping you from doing that? And we found that but for one kind of compliance issue that was a little fuzzy, in almost every case, the group was like, permission? Because all of these were habits, administrative procedures. It was not anything that was written in law, but it was just the way things were done, no communication. And without that kind of system being cleared out of all of the muck, it was almost impossible, not only for a person experiencing homelessness to solve the problem, him or herself, it was impossible for any one actor in the system to solve anyone's problem.
One of the crosswalks here is to a project called the Esther Project, which began in a county in Sweden called Jönköping County. Sweden funds its health care through counties, general taxation at the county level. Jönköping County is the best performer we've ever found. 300,000 people live there, and they have an amazing healthcare system. One of the reasons it's amazing is about now 15 years ago, maybe more, they invented Esther. Esther still is an 85-year-old woman or something with congestive heart failure and diabetes who lives alone and has a daughter in town but is occasionally depressed. And she needs help. And Esther became the central figure for planning. So they would get, the executive of the county would get everyone together, education, healthcare, transportation, and would say, what are we doing for Esther? And this metaphor was everyone had to look at Esther and figure out what their part of the solution was and how they depended on each other, and they still do it. They've invented a kid now, or they've invented, I think, another person, I don't know, but they still use this idea of the person at the center. I think the next step would be actually to have Esther there. And when they have parties, they have someone dress up like Esther. It's really weird.
Oh, Scandinavians. Any other questions?
Any further development around MRC, like the Medicaid redesign? Seeing that came out, I think that was a big merge with medical and housing that came together.
Not that I've seen. Medicaid you're talking about?
Correct.
Yeah. I actually had a session with the Secretary, Alex Azar, a couple of months ago and asked him about it because he had said that Medicaid was going to get more interested in housing and other social determinants. I think they're trying to. I think there are some regulatory barriers they're hitting, and I don't have, believe me, I have no inside track of that administration. But it makes a lot of sense, and we are seeing it happen at the state level. For example, I live in Massachusetts, which has had a Medicaid waiver now, and in the waiver is a really serious possibility of taking Medicaid funds and putting them into social determinants that it really matters. In England, which is fascinating right now, the English National Health Service, where I work a lot, has always kind of fallen short of this challenge of wedding health care to social care. Now, they've just published a document that's remarkable. I commend it to you. It's called the long-term plan, that's its name, of the National Health Service. Just came out in January, and it's a comprehensive 5-part vision of where they want to go with the National Health Service. And it absolutely includes this kind of merging of concerns about work on stuff that makes you sick instead of just running the repair shop. It's very cool.
Well, this has been amazing. Don, thank you for your generosity in being with us. Truly one of the most, the busiest, most committed people on the planet, and you spent the afternoon with us.
My pleasure.
We so
Thank
appreciate it. And
thank you.
If I'm correct, we've just got to get people around the table. We've got to have the person experiencing housing emergencies right with us. We need inside-out measures that are meaningful for making change. And above all, we need a clear aim, and a bold one.
And a ticker.
And a ticker on the right desk. Don, thank you.
Thank you.